Hi everyone and welcome to another video from our video series How to Answer the Most Common Pages. Today we'll be dealing with a patient who complains with pain. Let's get started. In order to adequately answer a page regarding a patient with pain, you need to know first what kind of pain medications we have, right? So let's start systematically, as we always do. We will first discuss the pain types, then the pain medication options we have, and then we will answer the page or the call from the nurse. Sounds good? Okay, so let's get started. Also, please note that in this video we will only discuss non-cancer pain. So please note, when I'm referring to pain, in this video I mean only non-cancer pain. We have three major pain categories: the neuropathic pain, the nociceptive pain or inflammatory pain, and the central sensitization. The stimulus for neuropathic pain is neurodamage, as you can see here in the slides, or pinching irritation. The neurons affected in the neuropathic pain are the nociceptor and non-nociceptor neurons. The site is peripheral nervous system or the central nervous system. And clinical examples include diabetic neuropathy, shingles, carpal tunnel syndrome, nerve lesion, etc. The stimulus for the nociceptive or inflammatory pain is injury or inflammation. The neurons affected are nociceptor and non-nociceptor neurons again. The site is again peripheral or central nervous system. And clinical examples for this type of pain is acute trauma, post-op pain, or arthritis. The central sensitization stimulus here is CNS dysfunction. The neurons affected are non-nociceptor neurons. The site is central nervous system, and clinical example include fibromyalgia. On this slide, as you can see here on the left side, we have medications, pain medications, which inhibit the ascending nociceptive pain transferal. This kind of medications include acetaminophen, NSAIDs, lidocaine, capsaicin, opioids, cannabinoids, and ketamine. Whereas we have another type of medications that facilitate the descending pain modification. These type of medications are gabapentinoids like gabapentin and pregabalin, sodium channel agents. These are the voltage-gated sodium channel blockers, in particular the antiepileptic drugs, carbamazepine, oxcarbamazepine, phenytoin, lamotrigine. Antidepressants like the TCAs, amitriptyline, comipramine, doxepin, imipramine, desipramine, nortriptyline, and the SNRIs, venlafaxine, duloxetine, milnacipram, etc. And the cannabinoids again and the ketamine also facilitate this type of pain modulation. All the signals from the peripheral nociceptor receptors are transmitted to the somatosensory cortex in the brain, which is located in the postcentral gyrus. The postcentral gyrus, you can remind yourself where it's located on the right upper side of this slide. The postcentral gyrus receives and processes sensory information like touch, pain, and vibration from the entire body. Now that we know the pain types, let's divide the pain into acute and chronic pain. In hospital settings, you will encounter patients with both acute and chronic pain. Like diabetes, pain is so common. Almost every patient I see every day in the hospital or in the clinic is on some sort of pain medications. It's a true pandemic, so you need to be well versed with the management of pain, being acute or chronic. Let's start with chronic pain first in inpatient settings, which means in hospital. And then we will discuss shortly the outpatient pain management. So if a patient is admitted to the hospital for whatever reason, and that patient was on chronic pharmacological pain management at home, you might want to restart these home pain medications, but only after speaking with the patient and confirming they actually take pain medications at home. You also need to determine the need for continuation of the pain medications and the exact doses they were taking at home. Don't just blindly restart pain medications, especially if they are on opioids, and we will see why in upcoming slides. If the patient cannot tell you for certain, in cases when they're poor historians or they have existent dementia or they're altered on admission, you can always contact family or their pharmacy to confirm the pain medications and their doses. Also consider any contraindications to pain medications like acute GI bleed and heart failure for the NSAIDs, severe constipation and low blood pressure for the opioids, but more about the side effects in the upcoming slides. And even if you don't restart the home pain medications, trust me, the patient, if they're really taking it and they're really in pain, the patient will wake you up in the middle of the night when you're on call asking for their pain medications. So one tip to remember is always consider restarting the home pain medications if no contraindications exist, obviously. And after, again, I cannot stress this enough, after confirming the dose and the indications for the pain medications. First line of chronic pain management as outpatient is a non-pharmacological approach, as you can imagine. First, you have to educate your patient on what pain is, how it's treated, side effects of pain medications. It's super important also to discuss the reasonable expectations for treatment response. For chronic pain management in patients with insomnia, you have to start with improving the sleep hygiene. You can also try cognitive behavioral therapy. Therapeutic exercise is recommended for every patient with chronic pain. You can try psychological approaches for these patients, also like the mind-body therapies, especially for those who have problems with mood, sleep, quality of life, and relationships with others. A trial of acupuncture also is an option for pain control. And if the non-pharmacological approach fails, then you can add some medications. This will be the pharmacological therapies based on the pain type, as we discussed before. You need to schedule follow-up visits. They're super important to promote patient education, treatment engagement, therapeutic alliance. You have to measure the pain on every visit. Is it improving? Is it getting worse? Interventional therapies and rehabilitation are reserved for patients who failed non-pharmacological and pharmacological therapies and still complain of persistent pain. So you must have heard of the World Health Organization pain relief ladder, right? A little bit of background: the WHO pain ladder was created in 1986 to provide adequate pain relief for cancer patients, alright? But after undergoing a lot of modifications over the years, now currently is applied for managing cancer pain, but also acute and chronic non-cancer pain. The key concept of the ladder is that it is essential to have adequate knowledge about pain first of all. Then you need to assess the degree of pain. Only after that can you prescribe appropriate medications. And this updated 4-step ladder, as you can see on this slide, focused on the quality of life predominantly. This is the latest version of the WHO pain relief ladder, the 4-step version. It has a bi-directional approach, extending the strategy to treat acute pain as well. For acute pain, as you can imagine, you can use the strongest analgesic as initial therapy and later taper down the pain medications, whereas for chronic pain, you need to apply a stepwise approach, starting from step 1 and going all the way to step 4 as needed. And after you reach step 4, you need to be mindful of always de-escalating pain management if possible. So the first step here is mild pain. Mild pain is treated with non-opioid analgesics such as NSAIDs or acetaminophen with or without adjuvants. The second step is moderate pain. We use here weak opioids like hydrocodone, codeine, tramadol with or without non-opioid analgesics, again NSAIDs and acetaminophen with or without adjuvants. Third step is for severe and persistent pain. Here we can use potent opioids like morphine, fentanyl, buprenorphine, hydromorphone, etc. with or without non-opioid analgesics and with or without adjuvants. And step 4 encompasses interventional and minimally invasive procedures such as epidural analgesia, intrathecal administration of analgesic, and local anesthetic drugs with or without pumps, neurosurgical procedures, neuromodulation strategies, nerve blocks, ablative procedures, cementoplasty, as well as palliation radiotherapy. The term adjuvant here refers to a lot of different drugs belonging to different classes, and although their use is typically for indications other than pain treatment, you can use them to help control pain in certain patients. Adjuvants are also called co-analgesics. They include antidepressants like the TCAs, such as amitriptyline, nortriptyline, the SNRIs, such as duloxetine, venlafaxine, anticonvulsants like gabapentin, pregabalin, topical anesthetics like lidocaine patches, topical therapies like capsaicin, corticosteroids, bisphosphonates, cannabinoids. So the take-home points from this letter are: first, start always with oral dosing of the drugs whenever possible, as opposed to intravenous or rectal administration. Around-the-clock administration rather than on-demand is better for pain control. Analgesic medications must be prescribed according to pain intensity, so every time you have to evaluate the patient for pain intensity. Normally we ask the question, how bad is your pain on a scale from 1 to 10, 10 being the worst pain. Individualized therapy is very important, and it is a big challenge in pain medicine to try to balance the desired analgesic effect and trying to minimize the side effects of the pain medication, especially the opioids. We're gonna see this in the upcoming slides. Let's address some take-home points regarding nociceptive and neuropathic pain first, before we move on to the pain medications themselves. So we're gonna start with pharmacological therapy for nociceptive pain first. Just remember one thing: for acute musculoskeletal pain, number one medication is NSAIDs. If the patient doesn't have any contraindications to NSAIDs, oral NSAIDs are obviously preferred. You can also use topical NSAIDs if you have like localized arthritis or superficially located joints like hand, wrist, foot, ankle. So if you have a patient who you think has nociceptive pain but he is not improving on NSAIDs, then you have to think of whether this patient has the other two types of pain, like the neuropathic pain or the central sensitization, or a combination of both. And you have to add on different type of medication like pain relieving antidepressant, antiepileptic, etc. You can use opioids for acute nociceptive pain. Please remember, do not use opioids long term for nociceptive pain, alright? The benefits do not outweigh the potential risk for opioid use. Moving on to pharmacological therapy for neuropathic pain. How we manage these patients is with selected antidepressants like the tricyclic antidepressants or the serotonin norepinephrine reuptake inhibitors. We also use certain antiepileptic drugs like the gabapentin and pregabalin, with adjunctive topical therapy like topical lidocaine, capsaicin patch when pain is localized. The choice among these treatments has to be individualized based on the patient comorbidities and medication side effects, costs, etc. For example, you're going to start an antidepressant first if the patient is depressed, or you can start with a gabapentinoid first when antidepressant drug interactions or side effects are a problem. Combination therapy with both antidepressant and antiepileptic drugs is often required because only less than 1/2 of the patients with neuropathic pain will respond to a single agent, so most of the time you'll be treating them with a combination therapy. Opioids, they have uncertain efficacy. Please consider them as second and third option. They are reserved for patients with high severity intractable pain, episodic exacerbations of severe pain, or neuropathic cancer pain. Now let's review each class of pain medications with their side effect profile. Think of them as two major groups: non-opioids and opioids. From the non-opioid analgesics, the most commonly used are the NSAIDs, acetaminophen, certain antidepressants, and selected anticonvulsants. So let's start first with the NSAIDs. From the NSAIDs, we have the non-selective COX-1, COX-2 inhibitors like ibuprofen, naproxen, ketorolac, diclofenac, indomethacin, and the selective cyclooxygenase 2 COX-2 inhibitors, celecoxib, etorocoxib, basically the coxib drugs. The COX-2 inhibitors do not damage the GI tract as much as you know probably, but can enhance platelet aggregation, which is their main disadvantage, and you need to remember this. And both the non-selective and selective NSAIDs are indicated for mild to moderate pain, particularly of musculoskeletal origin, as we saw earlier in the WHO pain letter. NSAIDs, as you know, act by inhibiting the production of several inflammatory mediators. If you don't remember the arachidonic acid pathway, this is a good time to remind yourself of that pathway. So basically, NSAIDs inhibit the production of prostaglandins, leukotrienes and thromboxane by inhibiting the enzyme cyclooxygenase. Prostaglandins and leukotrienes, as you might know, they don't cause pain directly, but they potentiate the effects of other inflammatory markers that can cause pain, such as bradykinin, serotonin, and histamine. They're also very potent pyretic agents and dilators of the vascular smooth muscles, which can lead to, guess what, vasodilation and edema, especially during acute inflammation. So by NSAIDs inhibiting the production of prostaglandins and leukotrienes, you can explain why they have anti-inflammatory, antipyretic, and analgesic effects. Side effects of NSAIDs is a big deal. They are associated with gastropathy, renal toxicity, platelet inhibition, and cardiovascular risk, in addition to many drug-drug interactions. The gastric ulceration and GI bleed mechanism of action, let's discuss that as it is very important. So the prostaglandins produced by the COX-1 help maintain the integrity of the barrier that is protecting the gastric mucosa, right, from the damage of the gastric acid. So all NSAIDs, by blocking the prostaglandin production, have the potential to cause gastric ulcers and GI bleeds. By the way, the only exception appears to be paracetamol, as it only inhibits prostaglandin synthesis centrally. The mechanism of action of renal toxicity caused by NSAIDs is by inhibiting the renal prostaglandins, and by doing that, they can decrease the renal blood flow via the lack of the vasodilatory actions of the prostaglandins in the kidney. So in healthy, well-hydrated healthy person, you won't see any side effects, but if the patient becomes volume depleted or has pre-existing renal insufficiency or is taking ACE inhibitors, then these side effects become more prominent. So keep that in mind. It has been proven that both the selective and the non-selective NSAIDs are associated with increased risk of cardiovascular events like death, myocardial infarction, heart failure, and stroke. So always prescribe NSAIDs at the lowest effective dose for the shortest duration possible. So if you have a patient without cardiovascular disease and in whom you have to prescribe NSAIDs, you can definitely do so, but just be mindful of the side effects. And the most commonly used ones are naproxen and ibuprofen, as they are the cheapest ones. If you have a patient without the cardiovascular disease but with GI factors, now it becomes tricky. For example, he has a history of GI bleed, or he has been using another antiplatelet agent, and you need to give them NSAIDs, particularly for long term, which is over 1 month. You can use the COX-2 inhibitors, which is the coxib drugs. Celecoxib is a good option rather than the other NSAIDs. And if you have a patient with established cardiovascular risk factors who require NSAIDs, then you can give them another class of pain medication like acetaminophen, for example. And let's quickly remind ourselves about aspirin and what is aspirin. Aspirin is an NSAID, but the mechanism of action of aspirin is dose dependent. In low doses, like the 81 milligrams a day, it irreversibly blocks the COX-1 enzyme, and by inhibiting the thromboxane A2, we'll have antithrombotic effect. In intermediate doses, starting 650 milligrams to 4 grams a day, aspirin will inhibit both COX-1 and COX-2 enzymes, and thus will block the prostaglandin production, and will achieve analgesic and antipyretic effect by doing that. In super high doses, between 4 and 8 grams a day of aspirin, will particularly block the COX-2 dependent PGE2, but these super high doses of aspirin are not used because of the toxicity related with high doses of aspirin, which include tinnitus, hearing loss, and GI bleeds. Moving on to the non-opioid analgesic acetaminophen. Acetaminophen is used mainly for acute pain. It's not used for chronic pain. There is limited data on that. Mechanism of action of acetaminophen is uncertain. We're not going to go into that. What is very important for us to know in clinical settings is the maximum daily dose of acetaminophen. For adults is 4 grams daily. For adults with liver disease is 2 grams daily, and for elderly is 3 grams daily. Big side effect of acetaminophen is hepatotoxicity, so you have to decrease the dose in half, the maximum daily dose, as we saw earlier. It's contraindicated in chronic kidney disease. In patients with hypertension, you have to be very careful giving acetaminophen. It can also cause chronic daily headache and peptic ulcer disease. Moving on to non-opioid analgesics, the antidepressants. Both the tricyclic antidepressants, the TCAs, and the serotonin norepinephrine reuptake inhibitors, the SNRIs, possess analgesic qualities, if you didn't know. These so-called analgesic antidepressants provide pain relief separate from their antidepressant effects, and they have analgesic effect even in patients who are not depressed. Noticeable analgesic effect though may require 2 to 4 weeks of antidepressant therapy, so keep this in mind. And you also have to be very careful with tapering and discontinuing the antidepressants. You shouldn't be stopping abruptly or rapidly tapering down the antidepressants, as you can cause agitation, anxiety, chills, diaphoresis, dizziness, dysphoria, fatigue, headache, insomnia, irritability, myalgias, rhinorrhea, tremor, etc. etc. SNRIs work by upregulating the descending inhibitory pain pathways. Duloxetine is indicated for chronic musculoskeletal pain, fibromyalgia, osteoarthritis, and peripheral neuropathic pain. It should be avoided in patients with hepatic or severe renal insufficiency. Milnacipran is indicated for fibromyalgia. It is the only FDA-approved medication for fibromyalgia. It inhibits the norepinephrine reuptake more than the serotonin inhibition, and thus it's thought to have more potent effect on both neuropathic and centralized pain conditions. Venlafaxine is used for acute and chronic neuropathic pain management. Cardiac conduction abnormalities unfortunately have been reported with venlafaxine, and also blood pressure can increase with use of venlafaxine, so be mindful of these side effects in patients with cardiac disease. The tricyclic antidepressants, they have independent analgesic effects in addition to relieving depressive symptoms associated with chronic pain. TCAs should be started at very low doses, with dosing slowly escalating as tolerated. Side effects of TCAs include anticholinergic effects, antihistaminic effects, and alpha-1 adrenergic receptor blockade, and on top of that cardiac effects like prolonged QT interval and prolonged conduction through the AV node. TCAs are relatively contraindicated in patients with severe cardiac disease, particularly when you have conduction abnormalities. Nortriptyline is preferred first choice in view of less side effects. The fact about nortriptyline is that it is actually used in the management of reflux hypersensitivity or functional heartburn if PPI therapy fails, or as add-on therapy to PPI treatment. Amitriptyline from all the TCAs has the most sedating and most potent anticholinergic effects. It is the first choice in patients who have sleep disturbances, and keep in mind that you can avoid the anticholinergic effects by administering low doses of TCAs at bedtime. We have 3 antiepileptics: gabapentin, pregabalin, and carbamazepine. They are among the 5 FDA-approved medications for treatment of neuropathic pain. Gabapentin and pregabalin are used for treatment of post-herpetic neuralgia and painful diabetic neuropathy. Pregabalin specifically is the only FDA-approved medication for the treatment of neuropathic pain associated with spinal cord injury. Both pregabalin and gabapentin bind to voltage-gated calcium channels at the alpha-2 delta subunit in the central nervous system. Side effects of both of them are dose-dependent. Dizziness, sedation, respiratory depression has been also reported in older patients, so be mindful of that. Most of the patients in hospital settings are elderly, so be very careful when prescribing these medications, especially if patient has respiratory problems pre-existent. Also remember that gabapentin can be sedating, so start always with low doses. Carbamazepine is the first-line treatment for trigeminal neuralgia. These topical agents may be used as first-line therapy for very well localized nociceptive or neuropathic pain. The transdermal NSAIDs can be found in the form of gel, spray or cream. They can provide relief for acute musculoskeletal pain when you have a single joint osteoarthritis, for example. Topical lidocaine is very oftenly used for neuropathic pain as second-line treatment. It is also used for chronic pain like post-herpetic neuralgia or painful diabetic neuropathy. It comes in the form of patch or plaster, used with caution in patients with hepatic, renal or cardiac dysfunction. Capsaicin cream. This is the cool one. It's actually derived from chili peppers and it is an over-the-counter medication. It is also used again in post-herpetic neuralgia, HIV neuropathy, diabetic neuropathy, and in patients with osteoarthritis in one or few joints. Major side effects of capsaicin are burning, stinging, and erythema at the site of application, leading to intolerance in most people. Moving on to opioids, as you can remember from the WHO pain letter, we had weak and potent opioids. This is an extended list of the opioid medications that we have. The weak opioids include hydrocodone. It comes only in combination with acetaminophen. The brand name is Norco. It is very commonly used. Another weak opioid is codeine, and we have tramadol, which can be found in combination with, again, acetaminophen. Brand name is Ultracet. From the potent opioids, we have morphine. You can give morphine in liver failure patients. We have methadone, also can be safely given in patients with CKD. Fentanyl can be also safely given in patients with CKD, and by the way, it is the most abused opioid in the United States. Oxycodone can be found in combinations with aspirin, ibuprofen, and APAP stands for acetaminophen here on the slide. Buprenorphine, it is most commonly used for maintenance treatment for opioid use disorder, but can be used as an opioid for acute pain. Another potent opioid is tapentadol. Another super potent opioid is hydromorphone, brand name Dilaudid. It is safe to use in patients with liver failure. Just for your reference, it is so potent that 1 milligram of IV Dilaudid equals 8 milligrams of IV morphine. And another potent opioid example is oxymorphone. General super important things to consider regarding opioids are the following. Please pay attention here. Don't ever use them for chronic pain management, as we said before. If necessary, always use them at the lowest effective dose and keep reassessing the risks and benefits for opioid use. Use them only if your patient has low risk for substance abuse and has persistent pain despite the other medications, pain medications that we discussed earlier. If opioids are indicated, always choose the immediate release formulations first, again at the lowest effective dose, and naloxone should be prescribed along with that. As you know, naloxone, the brand name is Narcan. It is an opioid antagonist and it rapidly reverses opioid overdose. Basically, it's an opioid antidote. But when prescribed together with opioids in treatment of pain, it prevents the so-called high state that gets people to become addicted to opioids. So you prescribe naloxone in attempts to help your patient not become addicted to opioids. The extended release formulations or the long-acting opioids are reserved only for those patients who are planned to be on long-term opioid treatment. And for patients who are already on long-term opioid analgesic therapy, please always consider tapering down or tapering off the opioids. Opioids come with a lot of side effects. The most important ones are nausea and vomiting. To overcome this, you can start them on antiemetics like prochlorperazine, promethazine, metoclopramide, meclizine, and ondansetron. Another side effect is pruritus. You can treat pruritus with non-sedating antihistamines like loratadine, hydroxyzine, and diphenhydramine. Opioids can cause respiratory depression. This is the big one. Obviously, you have to stop immediately the opioid. Just consider intubating your patient and give naloxone as an antidote. Sedation is a big side effect, another big side effect of opioids. If sedation occurs, you have to decrease the opioid dose. Also stop all the non-essential central nervous system acting medications like sedatives or anxiolytics if the patient is taking any of these. Myoclonus is also observed with opioids. Just try a different opioid and treat with benzos. Constipation is a big side effect of opioids. You should always consider starting the patient on bowel regimen when starting them on opioids to prevent constipation. Bowel regimens include Docusate, then you can add on Senna, then add on lactulose, then add on Miralax. And ultimately, you can start a patient on methylnaltrexone subcutaneously, especially for palliative care patients as last choice. Now, finally, let's answer that initial page or phone call from the nurse about our patient complaining of pain. Now, after this long discussion, I'm pretty sure you will know exactly what to do. As usual, starting off, when a nurse calls you to report a patient with pain, you need to ask them regarding the nature of the pain. Obviously, chest pain and leg pain will prompt a different workup and treatment, right? So if a patient has any of the 3 types of pain that we discussed earlier, you can follow the following steps. First, review the chart, check if the patient was taking any pain medications at home, were they restarted, can you increase the dose of the existing pain medications. Always check for existing contraindications to your planned pain management, as we discussed earlier. After that, you have to go at bedside and examine your patient. You need to determine how severe the pain is, which will tailor your pain management, obviously. The routinely asked question is, how bad is your pain on a scale of 1 to 10, 10 being the worst pain. Also, the moment you enter the room, you learn that you need to pay attention whether the patient is lying in bed comfortably or is really truly agonizing in pain. Please keep in mind that sometimes it so happens that the patients might be malingering in attempts to receive treatment with potent opioids. We use this all the time in the hospitals, and you need to be able to differentiate between someone who is in real pain and someone who might be lying to you. Opioids are very, very addictive, and you need to help anyone who you think is addicted to opioids to overcome their addiction somehow. But this is a whole different topic entirely. Consider imaging studies if they're indicated. This is a very important point. For example, if someone has a sprain or a fracture, keep this in your differential, especially if the pain is somewhere on the limbs like leg, shoulder, ankle, etc. After that, just follow the WHO pain ladder, and treat pain according to severity. Always start with the least potent and the least addictive, for that matter, pain medication, then increase the dose, then add adjuvants if appropriate, and then slowly transition to weak, then to potent opioids if needed, and then don't forget to taper down or taper off pain medications. And that's it, you guys. Now you're ready to help your patient with pain. Good luck. Thank you guys for watching another video from our video series on how to answer the most common pages. Please check out the rest of the videos on our channel in the playlist on how to answer the most common pages. I hope you guys enjoyed it and found it useful. Let me know in the comments below. Thank you very much for watching, and see you on the next video.